Hello everyone. In my today's lesson I'm going to talk about food allergy in children. Adverse reaction to foods consists of any untoward reaction following the ingestion of food or food additive, and they classically divided into food intolerance, which are adverse physiologic response, and the food allergies, which are adverse immunologic response, and they can be IG mediated or non-IG mediated. As with other atopic disorders, food allergies appear to have increased over the past 3 decades. Worldwide, estimates of food allergy prevalence ranges from 1 to 10%. Up to 6% of children experiencing food allergic reaction in the first 3 years of life, including approximately 2.5% with cow's milk allergy, 2% with egg allergy, and 2 to 3% with peanut allergy. Peanut allergy prevalence tripled over the past decade. Most children outgrow milk and egg allergies with approximately 50% during by school age. In contrast, 80 to 90% of children with peanut allergy, tree nut or seafood allergy, including fish, retain their allergy for later life. When we came to the pathogenesis, just to summarize, food intolerance are the result of varieties of mechanisms, whereas food allergy is predominantly caused by IgE-mediated and cell-mediated immune mechanisms. In susceptible individuals exposed to certain allergens, food-specific Ig antibodies are formed that bind to the Fc receptors on mast cells, basophils, macrophages, and also dendritic cells. When food allergens penetrate mucosal barriers and reach cell-bound Ig antibodies, mediators are released that induce vasodilation, smooth muscle contraction, and mucus secretion, which result in symptoms of immediate hypersensitivity, allergy. Activated mast cells and the macrophages may release several cytokines that attract and activate other cells such as eosinophils and lymphocytes, leading to prolonged inflammation. Symptoms elicited during the acute Ig-mediated reaction can affect the skin. For example, on skin we can see urticaria, angioedema, and flashing. They can also affect the gastrointestinal tract, such as oral pruritus, angioedema, nausea, abdominal pain, vomiting, and diarrhea. Also, it can involve respiratory tract with manifestation of nasal congestion, rhinorrhea, nasal pruritus, sneezing, laryngeal edema, dyspnea, and wheezing. Sometimes it can also involve the cardiovascular system, and it can cause dyserythmia, hypotension, loss of consciousness if it causes anaphylaxis. In non-Ig mediated food allergies, lymphocytes, primarily food allergen specific T cells, secrete excess amount of various cytokines that lead to a delayed, more chronic inflammatory process affecting the skin, GI tract, and respiratory tract. Mixed Ig and cellular responses to food allergens can also lead to a chronic disorders such as atopic dermatitis, asthma, eosinophilic esophagitis, and also gastroenteritis. Genetic factors play an important role in the development of food allergy. Children who develop Ig-mediated food allergies might be sensitive by food allergens penetrating the GI barrier. Those are referred to as class 1 food allergens. Whereas those children who have Ig-mediated food allergens that are partially homologous to plant pollens penetrating the respiratory tract, they are referred to as class 2 food allergens. Any food may serve as a class 1 food allergen, but egg, milk, peanuts, tree nut, fish, soy, and wheat account for 90% of food allergen during childhood. Many of the major allergenic proteins of these foods have been well characterized, and there is a variable but significant cross-reactivity with other proteins within an individual food group. Exposure and sensitization to these proteins often occur very early in life. For example, virtually all milk allergy develop by 12 months of age, and all are egg allergy by 18 months, and also the median age of first peanut allergic reaction is around 14 months. Class 2 food allergens are typically vegetables, fruits, and also nut proteins that are partially homologous with pollen proteins. With the development of seasonal allergic rhinitis from grass or any other thing, Ingestion of certain uncooked fruits or vegetables provokes the oral allergic syndromes. Intermittent ingestion of allergenic foods may lead to acute symptoms such as urticaria or anaphylaxis, whereas prolonged exposure may lead to chronic disorders such as atopic dermatitis and asthma. Cell-mediated sensitivity typically develops to class 1 allergens. When we came to the clinical manifestations of food allergy clinical manifestations can involve any organ. From this, let us see the most common ones. Food allergy, gastrointestinal manifestations of the food allergy are often the first form of allergy to affect infants and young children, and typically manifests as irritability, vomiting, spitting up, diarrhea, or poor weight gain. Cell-mediated hypersensitivity without Ig involvement predominates, making standard allergy tests such as skin prick test and in vitro tests for food-specific Ig antibodies of little diagnostic value. The other system affected is skin. The cutaneous food allergies are also common in infants and young children. Atopic dermatitis is a form of eczema that generally begins in early infancy and is characterized by pruritus, a chronically relapsing course, and associated with other allergic disorders such as asthma and allergic rhinitis. Although not often apparent from history, at least 30% of children with moderate to severe atopic dermatitis have food allergies. The younger the child and the more severe the eczema, the more likely food allergy is playing a pathogenic role in this disorder. The other manifestation of the dermatologic manifestation of the food allergies, acute urticaria and angioedema. They are among the most common symptoms of food allergic reactions. The onset of symptoms may be very rapid within minutes after ingestion of the responsible allergen, and also symptoms result from activation of Ig-bearing mast cells by food allergens that are absorbed and circulating rapidly throughout the body. Foods most commonly incriminated in children include egg, milk, peanut, and nuts, although reaction to various seeds can occur. Chronic urticaria and angioedema are rarely caused by food allergies, but acute urticaria and angioedema is mostly caused by food allergies. Perioral dermatitis is often a contact dermatitis caused by a substance in the toothpaste, gums, lipsticks, or medications. And perioral flushing is often noted in infants fed citrus fruits and may be caused by benzoic acid in the food. It may also occur during nursing. In both situations, the effect is benign. Flushing may also be caused by other things, which is familial, or other problems which resolves spontaneously. When we came to the respiratory system, respiratory food allergens are uncommon and as an isolated symptoms. Although many parents believe that nasal congestion in infants is often caused by milk allergy, studies show that this is not the case. Food-induced rhinoconjunctivitis symptoms typically accompany allergic symptoms in other target organs, such as skin, and consist of typical allergic rhinitis symptoms, such as periocular pruritus, tearing, nasal congestion, and pruritus, and also sneezing and rhinorrhea. Wheezing occurs in approximately 25% of Ig-mediated food allergic reactions, but only 10% of asthmatic patients have food-induced respiratory symptoms. The other manifestation is the severe form, that is anaphylaxis. This is defined as a serious multi-system allergic reaction that is rapid in onset and potentially fatal. Food allergic reactions are the most common cause of community onset anaphylactic reaction, whereas in hospital, drugs are the most common. In addition to the rapid onset of cutaneous, respiratory, and GI symptoms we discussed above, patients with anaphylaxis secondary to food allergy demonstrate cardiovascular symptoms including hypotension, vascular collapse, and cardiac dysarrhythmia, which are presumed to be caused by massive mast cell release mediators. Food-dependent exercise-induced anaphylaxis occur more frequently among teenage athletes, especially females. The other thing is about the diagnosis of the food allergy. A sort of medical history is necessary to determine whether a patient's symptomatology represents an adverse food reaction, that means intolerance, or a food allergic reaction. The following factors should be established: the food suspected of provoking the reaction and the quantity ingested, the interval between ingestion and the development of symptom, the type of symptoms elicited by ingestion, whether ingesting the suspected food products similar symptoms on other occasion previously, the interval from the last reaction to the food. So history is very important to determine whether the patient symptom is due to food intolerance or food allergy. Skin prick test and in vitro laboratory tests are useful for demonstrating IgE sensitization, defined as the presence of food-specific IgE antibody. A negative skin test result virtually excludes an IgE-mediated form of food allergy. Whereas in opposite, most children with positive skin test responses to a food do not react when food is ingested. So more definitive tests such as quantitative IgE tests or food elimination and the challenge are often necessary to establish the diagnosis of food allergy. When we came to the treatment, appropriate identification and elimination of foods responsible for food hypersensitivity reactions are the only validated treatment for food allergies. Children with asthma and IgE-mediated food allergy, peanut or nut allergy, or a history of a previous severe reaction should be given a self-injectable epinephrine and a written emergency plan in case of accidental ingestion. Because many food allergies are outgrown, children should be re-evaluated periodically by allergists to determine whether they have lost their clinical reactivity or not. Most children with egg and cow milk allergy outgrow, whereas those children who have peanut and fish allergy have a chance of persistent allergy to those things. For example, egg age of resolution is expected is around 7 years in 75% of cases, and whereas cow's milk 76% of cases resolve at 5 years of age. When we came to peanuts, age of resolution, it is almost 20% of cases resolve to up to the age of 18 years. So most of them are persistent. When it came to the prevention of food allergy, breastfeeding exclusively for 4 to 6 months have a good method of preventing food allergy, not only food allergy, all allergic diseases. Breastfeeding exclusively for 6 months and continuing breastfeeding up to 2 years decrease the chance of having asthma, allergic rhinitis, and also food allergy. We should have to also introduce solid foods after 6 months of exclusive breastfeeding. Then we introduce low-risk complementary foods one at a time. Introduce a potentially highly allergic foods soon after the low-risk foods are adapted. No need to avoid or delay. Previously, the recommendation is to delay or to avoid highly allergenic foods such as eggs, milks, and peanuts up to the age of 1 year to decrease the chance of having allergic disease. But currently, the recommendation is to start early after the child adapts low-risk complementary foods. And also, there is no need of avoiding allergenic foods during pregnancy or nursing to avoid a chance of having a baby who have allergic disorders, especially food allergies. Thank you. Don't forget to subscribe and like the page for additional pediatric lectures.